Jason, and I think as your last talk, a lot of this is going to be old news.
So I can flip through the background very quickly. So I think it's well agreed upon right now that inflammation and persistent immune activation are driving long-term comorbidities in children living with HIV. And there have been some specific inflammatory biomarkers linked with risk of cardiovascular disease, and these are listed here. What's interesting is that even with sustained viral suppression, and this is data from adults, inflammation persists, and it's thought that it's actually the maintenance of the HIV reservoir, so the immune system kicking in to combat that existing reservoir that's contributing to persistent inflammation. So our study objective was to really look at the association between the HIV reservoir size and biomarkers of cardiovascular inflammation in our Canadian cohort of children living with HIV. And very quickly, just a word about the different reservoir measures that you might have heard about and that we've used in this study. So what we're all trying to look at is that latent reservoir pool in your resting CD4 cells. And there are many different methods to categorize this. I think the easiest, the cheapest, and the fastest way to do it is to look at the total HIV DNA PCR content. But as has been mentioned, that overestimates the reservoir size because we have a lot of defective virus in there. So other methods include sequencing for defective virus. And a novel method was to stimulate those resting CD4 cells and to subsequently quantify the available HIV RNA. And so in our study, what we did is we looked at the total HIV DNA PCR quantity, and we did a stimulation assay called this prostratin stimulation assay and quantified the inducible RNA levels. And we measured soluble plasma levels of these biomarkers. So what did we find? And who do we do this with? So this is our Canadian cohort. So it was a cohort that started in 2014 of children living with HIV in Canada who were followed every 3 to 6 months. We essentially exsanguinated them at every visit, taking about 20 to 25 mLs of blood for our reservoir measures. And the primary objective was to look at reservoir size, but also the role of co-infections and the impact on systemic inflammation. And so when you look at our overall cohort of 225, 182 had viral suppression at baseline. And so these were divided into 4 different groups, similar to what the other reservoir studies have done. Group 1, or let's say our top 10, so these kids initiated treatment very early, often within hours of birth, but we categorize them as at least within 6 months of birth, and who had at least 5 years of viral suppression, but some were in their teens with viral suppression. Group 2 started after 6 months, but again, had at least 5 years of viral suppression. Group 3 failed at least one treatment, but at least achieved 5 years of suppression. And group 4 was more heterogeneous, but at the time of their baseline visit had at least 2 years of viral suppression. So this is not surprising that the total proviral DNA PCR content varied according to groups, and group 1, our top 10, had very low to undetectable levels. But there was a lot of heterogeneity in groups 2, 3, and 4. So when we looked at the inducible RNA levels, these correlated more to the groupings, and we definitely had changes according to the timing of their treatment. So we used inducible RNA as the measure of our reservoir for our inflammatory biomarkers. And so what did we find? And again, not surprising, similar to what the other cohorts have found, we found that age at treatment initiation, the duration they'd been on treatment, and we calculated the proportion of life that that child had had sustained viral suppression. These were all predictors of the inducible reservoir by inducible RNA. And these correlated to, of all the measures we looked at, to CRP, IL-6, IL-18, and IL-1 beta. And these were just straightforward correlations. So we had an association between this reservoir. And what we like about this reservoir measurement is that it's not just one snapshot of your viral suppression, it's really your history of your HIV control. So it looked like this was associated with these markers of inflammation. We then decided to adjust for CMV co-infection. As we mentioned, its role in maintaining the reservoir is still to be established, but we have done work showing that it does alter the immune profile of children living with HIV, just being CMV seropositive. And its role in reservoir is still not clear, but there is, and this is our preliminary data, some data to show that among the really well-controlled children, it might be leading to increasing reservoir. So when we adjusted for CMV, there was no difference in this association with these inflammatory biomarkers. And finally, we tried to categorize these biomarkers according to the presence of any or no reservoir. And here there is really no statistical significance between the groups, but again, the strata are very small. So our top 10 in that upper left, group 1, had only 10 measures. So it's hard to establish statistical significance, but it doesn't look like there was any difference according to the groups. So in summary, in these children living with HIV with sustained viral suppression, the reservoir size was associated with markers of cardiovascular inflammation. And this suggests that I think simple viral suppression isn't enough, and that the persistence of the reservoir may be contributing to long-term systemic inflammation. And as a clinical impact, it really reinforces to me the need for the interventions that minimize the size of the reservoir, such as preemptive HIV therapy, and the potential role for new anti-inflammatory agents or adjunctive agents for children who are well suppressed to minimize inflammation. So with that, I end, and a thank you to our entire study and cohort team.